A patient presents following a head injury. I am showing you the lateral radiograph of the skull. Describe the findings.
Let's see. Yes. The lateral radiograph of the skull demonstrates marked widening of the diploic space and thinning of the outer table of the skull vault. There are multiple, thin, vertical bone striations perpendicular to the inner table, creating a classic hair-on-end appearance. Importantly, this striated bone expansion spares the calvaria below the level of the internal occipital protuberance. Additionally, there is complete obliteration of the maxillary sinuses due to expansion of the facial bones. The diffuse distribution and maxillary sinus obliteration are highly characteristic of thalassemia major.
What is the differential diagnosis for a hair-on-end appearance of the skull, and how do we differentiate the most common causes?
The mnemonic for a hair-on-end appearance is STAN, representing sickle cell disease, thalassemia major, other anemias like hereditary spherocytosis or glucose 6-phosphate dehydrogenase deficiency, and neoplastic causes such as haemangioma and neuroblastoma metastases. To differentiate thalassemia major from sickle cell disease, we evaluate the maxillary sinuses. In thalassemia major, severe marrow hyperplasia involves the facial bones and obliterates the maxillary sinuses. In contrast, the maxillary sinuses are typically spared in sickle cell disease. Furthermore, neoplastic causes like haemangiomas are usually focal rather than diffuse.
I am showing you a comparison radiograph of a skull lesion. Describe the findings and the diagnosis.
The comparison radiograph of the skull vault demonstrates a localized area of thickened and coarsened trabeculations, presenting a corduroy or sunburst-like pattern. Unlike the diffuse, thin vertical striations of thalassemia, these trabeculations are much thicker and are confined to a single circumscribed focal lesion. This represents a benign intraosseous skull hemangioma, which is characterized by thickened trabeculae running between vascular channels. This illustrates how a localized neoplastic lesion differs from the generalized marrow hyperplasia seen in severe systemic anemias.
Discuss the underlying pathophysiology and complications of marrow hyperplasia in thalassemia major.
In thalassemia major, ineffective erythropoiesis and chronic severe hemolytic anemia cause a massive increase in erythropoietin secretion. This triggers profound compensatory red marrow hyperplasia. The expanding marrow thins the outer table and causes osteopenia, while the remaining trabeculae remodel into parallel vertical plates perpendicular to the table, creating the hair-on-end appearance on radiographs and CT scans. On magnetic resonance imaging, this pattern is represented by alternating bands of low-signal trabeculae and high-signal hyperplastic marrow. The skull changes spare the area below the internal occipital protuberance because it normally lacks active marrow.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these radiographs with prior skull films to assess the progression of marrow hyperplasia and evaluate for secondary complications. I would suggest obtaining a dedicated non-contrast CT of the head and face if there are clinical concerns of sinusitis or to better delineate the paranasal sinuses. I would also recommend a chest radiograph to evaluate for cardiomegaly and paraspinal masses representing extramedullary hematopoiesis, and an abdominal ultrasound to check for hepatosplenomegaly and gallstones. I would communicate the findings to the pediatric hematology team to coordinate regular blood transfusions and iron chelation therapy.